wound debridement does play a part in the management of diabetic foot wounds. There are various methods, and I'm not going to advocate using just one method. I think we need to appreciate the relative methods of different strategies, and that there's a relatively poor quality of evidence in this area. I think on that note, I think it's important to recognize that for a complex problem, it seldom requires just a simple solution. So we need to have a multi-pronged, sustained strategy to manage a very complex problem that's been developing over many, many years. Debridement forms one of the key tenets of managing diabetic foot ulcers, which we've been discussing much of the day, and it's probably one of the more important ones, arguably. I work with Dr. Casey Graham a little bit from trying to make sense of the literature and what the appropriate approach is, and I know in his clinic he also struggles with some of the smaller wounds, whether to take them to the operating room or debride them in the clinic, and relatively poor resource centre in Canada for specifically this type of patient. But there are some patients where we've obtained wound closure. I would be lying if I said we managed to get wound closure in all of them. We struggle through and use different strategies. But there's a lot of industry-sponsored bias, and there's relatively dearth of quality studies, and it's also difficult in this population to standardize in a very heterogeneous group of subjects and their course. So I think sometimes the circumstances and the resource limitations dictate one's approach more than the indication and the patient factor, actually. So I've always sort of approached complex chronic wounds using the traditional nursing approach of time, which is looking at the tissue and the features of infection, inflammation, and then the moisture balance. Is it dry, is it wet, and then what does the wound edge look like? Does it look like it's advancing, or does it look like it's stagnating? And I think that has helped me to make sense of the wound. And then I think, as mentioned earlier, I'd like to see that the wound is closing at a rate of about 10% a week, which many of these patients just doesn't happen. I think it's important also, as I mentioned earlier, to know what's available to you, and it would depend on your background and training. What is in your toolbox, what is available to you, and what's your repertoire. I think if you've only got a hammer, everything's going to start looking like a nail, right? So there are a number of strategies to debride, and many of these I use routinely in the practice of managing major burns. Of course, the gold standard, I think, against which many things have to be judged in my context is probably sharp debridement, but probably in this context, I think the gold standard may be now a dressing of some form, maybe a hydrogel. The traditional approach of wet to dry is often referred to as the gold standard because that's what has been used for generations. But there are some newer strategies and some strategies that have been used over a long time that are coming back, like maggot therapy, and then some new technology like ultrasound and different variations of that. And then I'm quite excited about the newer negative pressure wound therapy with installation and dwell, which I regard as the most active dressing modality we have at the moment, because there is a degree of debridement that comes with that, with the installation and dwell technology, particularly the new foams that are available and various fillers that are available, rather than just the fluid that's instilling. I think debridement is one of those things that gets to, they're not properly taught at various stages of training, and yet it's so fundamental to any surgical specialty. So we know that removing the dead or devitalized tissue is critical to changing what Gillies would have referred to as a chronic wound to an acute wound. It's a fundamental principle of plastic surgery to allow the normal wound process to proceed. But I think, as is based on some literature in Europe suggesting that 3/4 of wounds will heal if those tenets are adhered to. So this is a wound we managed a while ago. We debrided a wound, it's been debrided and it's eventually closed. because we've stuck at it, and many of these wounds in the clinic setting need to be debrided more than once. I think if one has the opportunity of taking someone to the operating room, it's arguable you could be a bit more aggressive. You may not need as many sessions as you would with a clinic debridement, which would be a more conservative one, knowing that many of these patients are neuropathic and they may not feel as much. Many of them still feel, and I don't think they're going to be coming back to your clinic if you're going to be hurting them. So as I mentioned, converting a chronic wound to an acute one and allowing normal wound healing to cascade to progress is one of those fundamental points that we rely on. Then there is a little bit of literature to suggest the important role of debridement. There's some reviews and systematic reviews showing some improvement of that. In terms of what we do in the operating room, I think more than in any other category of patients, this group we need to really know our tissue, and we need to recognize what we're seeing as normal or abnormal. I'm not going to go into that in depth, but and that is why I tend to use a tourniquet, even though these patients aren't going to bleed like somebody who's got a normal blood supply. There will still be some bleeding, and bleeding would interfere with your assessment. So we do tend to use a tourniquet to visualize tissue if we're going to be delving deep into a wound. Again, minimal handling, tissue handling, good hemostasis, and tooth rather than crushing forceps. I just want to emphasize one point here, is that clearly the system of billing does not favor or does not support practitioners doing debridements, because if you look at the schedule of benefits, you're going to get $20 for a debridement. So if you're going to take someone to the operating room and do that, you're not going to make a living. So I think it's a shame that that's the case, but that's the reality. And obviously if you go involving bone, it might go up to about $60 or $90 if it's more than one wound. And in this area, I think that's important to note. So there are some techniques one can use that are effective, but may not need the time and resources involved in the main operating room. The other point that I wanted to emphasize, as I mentioned earlier, is this tendency for over-specialization has really set us back as surgeons. I think this idea that debridements should be, everything must be super specialized, and that people must only be doing a small area of things, has meant that a lot of us are able to say, well, I'm not working in that area, and therefore I shouldn't be doing debridements. That's for somebody else. That's part of the problem, and touched on what we were talking earlier, is that there's this ability to sort of delegate menial things to everybody else. I also wanted to sort of emphasize the value of staged surgeries. So addressing infection and debriding necrosis and edema before you start to consider closure as of value. And this applies to amputations, and it applies to smaller wounds in the foot. If you're considering closure, which we will be doing as plastic surgeons, there's often value in debriding first, assessing, maybe applying another strategy like negative pressure wound therapy or hydrogel or an enzymatic therapy before you consider, because you may be managing infection, and then there's less swelling that will mean that your closure is not under tension, and you're going to get a better result. I think edema is a big problem with wound healing here. So in terms of anesthetic choice, I've touched on that a little bit earlier, but there are a variety of different anesthetic choices you could choose, and it needs to be varied according to your patient. I use a lot of Versajet in my burn practice, which is a Smith & Nephew product, but I think it's most useful in a large granulating surface. For smaller wounds, maybe it doesn't justify the cost of the hand pieces. They are fairly expensive, but it is essentially uses the Venturi system, and what's generated is a vacuum within the operating surface, and I think that's it's a very effective method. The amount of depth that you debriding can be adjusted. This is the old-fashioned method I spoke about, the mechanical debridement, where you put something on, it's wet, and then you rip it off. It's painful. The dressing is inexpensive, but the nursing costs end up being high. There's some newer products that may be a little, using some of the principle like Debridement that maybe could be considered as well. Then, as I mentioned earlier, maybe a gold standard now is a hydrogel. We all believe that moist wound healing is of value, but there is also the concern in these patients who are at risk that moisture and infection go hand to hand. So one needs to be careful about that. There are some RCTs that suggest that hydrogels are preferable in that way than gauze, which would be using the alternative method. In terms of maggot therapy, I think this is coming back into vogue, and I think nowadays patients are happier with it if it's contained within a tea bag. It may not be as effective as those that run loose in the wound, but there's certainly some efficacy to it. They are, these larvae are highly specific to, they select out the necrotic tissue and tend to leave the normal granulating tissue. So it may be difficult for your patient to tolerate, but there's certainly some efficacy there. And there is a RCT on looking at that, demonstrating efficacy versus hydrogels. And this is a study published in the UK that's demonstrated across a whole variety of wounds that there is some improvement in outcomes, particularly those with necrosis in the context of trauma. I think this ultrasound is a technique that should be considered more and more in the outpatient setting. The reason for this is there's less pain than other techniques, and how it works is it causes a sort of a bubbling of the tissue that implode, and then the energy is dispersed across the cells. It stimulates the membranes of healthy cells, and it disperses biofilm, which I'll touch on a little bit in the context of negative pressure wound therapy. But I think there seems to be some good efficacy using the lower end of the ultrasound spectrum, 20 to 60 kilohertz, and using it a couple of times a week. So you need to do it frequently, but there's some value in using that. And I think given that there's less pain than other techniques, it's definitely of value. And I know some of my colleagues are using that. This is one of those systems and there's some case series showing some decreases in bioburden and some value in the vascular surgery population. So while it may be expensive outlay initially, I think for your patients it's of value. Then enzymatic debridements, further to types of dressings. These target various structures like the protein fibrin, collagen, and elastin. The Clostridium collagenase is probably the best known one, and it does selectively debride or break down non-viable tissue in the wound, and there's some evidence coming out that there's some improvement in outcomes or compared to standard dressings like antiseptics like silver. Although it needs to be used selectively. This is from my literature and burns showing some less selective use and some bad outcomes with it, so it needs to be used carefully. I think we're all familiar with negative pressure wound therapy. It was discussed in the context of incisional wound therapy previously. I just wanted to emphasize the value here in terms of the reduction in pain and fewer dressing changes with this modality. We do know that it generates good granulation. You're going to get good granulation only in normal tissue because of the positive pressure applied to the wound and the release of VEGF and nitric oxide. You generate some granulation, and wounds can heal probably quicker than any other wound healing modality. So there's some reductions in biofilm related to that. Just move quickly through the remainder. Biofilm was discussed in the previous section as to its impact on the propagation of wound infection. Outside you'll see in one of the stands this new foam that really does generate a rapid amount of granulation tissue in the context of wounds and helps to debride, which I mentioned earlier. Some improvements in outcome and granulation formation. The only caveat, I think, this is a case that we had where you're going to get improved outcomes over time with negative pressure, fewer dressings, and eventually wound healing because of the granulation tissue that's formed. The only caveat, I think, given that it is a positive pressure that's generated in the wound bed, is that if it's circumferential or too high, and I think it's artificial or incorrect to just apply the same pressure for all patients. It needs to be adjusted. And there's some evidence to show that tissue oxygenation is actually reduced with the application of negative pressure wound therapy in this category of patient, particularly when circumferentially applied. And you can obviously also, there was discussion about using beads, etc. earlier. I think it's important also to know that you can use antiseptics and use and preserve your antimicrobials for systemic use. So in summary, I think it's based on this Cochrane review, there's a dearth of literature in this area. There's a lot of work that needs to be done. And there's very few studies looking directly at all the methods. So larvae may be of use. There are a few studies that show that enzymatic or surgical debridement even are of value. So in summary, debridement we believe is valuable. The literature may not support that. It doesn't necessarily favor one over the other. I think we should use more than one strategy and adapt it to each patient. And I think in the context of a limb preservation service, the correct approach can be adapted to each patient. Thank you very much for your attention.